So hi friends, today I'll be talking about nephrotic syndrome, a brief overview on the clinical features followed by the management aspects. So nephrotic syndrome consists of a tetrad of four clinical features, that is proteinuria, followed by, if there's loss of proteins in the urine, there's hypoalbuminemia, that is like reduced albumin in the serum. Hypoalbuminemia manifestation is edema, and then followed by, if there's loss of albumin in the urine, our body will try to synthesize lipids, liver synthesis, like a counter mechanism. So that is manifest as hyperlipidemia. So let's take a overview on proteinuria. When do we say proteinuria happens? That is more than 3.5 grams per day of proteins are lost in the urine collected for 24 hours. In that, more than 3.5 grams per day, or based on the body surface area, if you go by, that's more than 40 mg per meter square per hour, okay, or 1 gram per meter square per day. This is based on the body surface area. So this is important quantification wise. You have to mention this clearly for Viva or even the exam to write this. So this is how you quantify proteinuria: 3.5 gram per day or 40 mg per meter square and 1 gram per meter square per day. Urine dipstick is like 3 plus or 4 plus if it is shown. That is consists to be significant proteinuria, and protein creatinine ratio is more than 2. This is proteinuria. So hypoalbuminemia is like when the serum shows less than 2.5 grams per deciliter of in the serum albumin, okay. Then edema is like manifest as facial puffiness and anasarca, followed by hyperlipidemia. That is like the triglyceride level should be more than 200 mg per deciliter. That's like the liver synthesis will counter produce, like counter mechanism kind of a thing. So this is the tetrad of features. As you can see, there's like edema is manifested as what? Facial puffiness, followed by generalized edema, that is like extremities and all that. Pedal edema, there'll be ascites and things like that. Okay, so you could take a snapshot here. Okay, let's go to the management. Okay, so coming to the management per se, nephrotic syndrome means most commonly seen in children is minimal chain disease. Okay. So as the name suggests, there's only minimal change. So you can see there'll be like issues in with respect to the podocytes. There will be like effacement of negatively charged food process of what? Podocytes. Okay, that is the issue. And this will be only seen in the electron microscopy. So this is that, you can't just see through any kind of, it is not that easy to find out about this. And most of the time this is idiopathic, this effacement, why it happens. So there will be what? There will be no, since there's effacement of the negatively charged food processes, like actually there should be repelling of negative charged proteins, right? No repulsion of for negatively charged proteins. And that's urine loss, okay. Urinary loss. Okay, so this is the basic thing. So remember that there's effacement, okay, of the food processes of podocyte. That is the major thing in minimal chain disease pathophysiology, if you go by. So this is seen only in an electron microscope. So let's begin. So minimal chain disease is thankfully steroid. It's a steroid sensitive type of nephrotic syndrome, okay. So this is steroid sensitive. So definitely our first line of drug will be what? A steroid, that is prednisolone. So initial episode of proteinuria, we know the quantification, how we will tell there's an initial episode of proteinuria. Then we should start with treatment, that is prednisolone. So prednisolone we give like a 6 weeks plus 6 weeks regimen. That's like a 2 mg per kg per day. Okay, you start initial dose, that's a high dose. Or you could just tell it as 60 mg per meter square per day. This 2 mg per kg per day is nothing but same as 60 mg per meter square. This is based on body surface area. You give the dose. Okay. So initially 6 weeks you start with on a high dose, that is 2 mg per kg per day until proteinuria resolves. This 2 mg per kg is now you can write in with respect to body surface area 60 mg per meter square per day. Okay. This is based on the body weight, this is based on body surface area, simple. So some places Ghai has given 60 mg, some places 2 mg, but they both are the same, okay. Just wanted to tell that. Or you could give based, or you should, and after that you should, of course, the steroids means you have to taper it. So taper it in the next 6 weeks with a low dose of 1.5 mg per kg per day on alternate day. That is nothing but based on body surface area, if you go by 40 mg per meter square per day. Okay, so you can write whatever you want, but I would be preferring this one based on body weight, 1.5 mg per kg per day on alternate day. That's how you taper it. Most of the time, this high dose time, when you give high dose, there only in the 6 weeks only it resolves most of the cases. Okay, so in this remission, how do we check for remission? Every day you should check for the proteinuria. So if that is less than 4 mg per meter square per hour proteins in the urine in 3 consecutive morning samples. This is very important for definition. So remission is when there's proteinuria of less than 4 mg per meter square per hour in 3 consecutive morning samples. 3 consecutive morning samples. That is remission. Okay. So the child is treated, sent home. But what happens? Now what if the child suddenly comes back with a relapse within 14 days of stopping the treatment? Within 14 days of stopping the treatment, the child comes back within 2 weeks or 14 days of stopping the treatment. Then that is considered to be a steroid dependent case, clearly, right? Because you are giving them steroids for 6 plus 6 weeks. There was no any symptoms in that time. Then there's like relapse suddenly after stopping treatment, clearly indicative of steroid dependent case. Sorry. Yeah, it's a steroid dependent case. Okay. Just keep that in mind. So coming to what is infrequent lapse. Now at 1 year of age, I treat the child. 1 year I treat the child. Then comes back to me after like when the child is 5 years, suddenly with another lapse of proteinuria or edema or something. That's an infrequent lapse. It will be more clear once I tell you what frequent lapse is. Again, infrequent lapse is what? When there's like proteinuria of more than what? 40 mg per meter square per hour, right? We know this through the definition, like we learn in that tetrad of features, right? This quantification. So that is how it is. Like definition had this infrequent lapse when you find proteinuria of this based on body surface area. Okay. So again, here also prednisolone is only the first line of treatment. Same dosage, 2 mg per kg per day, or this is nothing but 60 mg, right? Based on meter square per day. Okay. So that's again for 6 weeks. Same thing. This is for 6 weeks itself. But the 1.5 mg per kg per day is for only 4 weeks. So initial was 6 plus 6. But after this infrequent lapse is only for 4 weeks you give here. Okay. On alternate day treatment. There's 1.5 mg per kg per day on alternate day treatment for 4 weeks. So alternate day treatment is like what? One day I'll give the child steroids. One day I won't give the child steroids. One day I'll give. One day I won't give. That's like alternate day. Like this it goes for 4 weeks. Right. So clearly, now if I see that there are symptoms in this when I'm not giving steroids, then what does that suggest of? The child is a steroid dependent case. So 2 or more lapses, like this 2 or more lapses on alternate day treatment, that is also considered to be steroid dependent. So there are 2 components in steroid dependent cases, or like you should define steroid dependence. That is lapse within 14 days of stopping the treatment, or 2 or more lapses on alternate day treatment. That is considered to be a steroid dependent case. So that is steroid dependent case. Okay, so let's keep that in mind. Okay, so clearly if this is steroid dependent case, means you can't be giving steroid in every relapse the child is having, right? That means you have to avoid steroids, stop the steroids, because steroid itself has a baggage of steroid toxic features like hair loss, reduced bone density, osteoporosis, and then we have Cushingoid features like what moon phase, like there could be like what buffalo hunger, like that. So with time there could be a lot of Cushing's related like steroid related toxic feature that child can develop. So avoid steroids and start on immunomodulators like levimazole and mycophenolate mofetil. Ghai mentions also about cyclophosphamide also. Just you can write it there. Okay, so dosage wise, remember only prednisolone dosage, that's more than enough. Levimazole, mycophenolate mofetil, and cyclophosphamide, that is immunomodulators. Okay, so that is like in steroid dependent case, you have to avoid steroid toxicity, stop avoid steroid toxicity and start immunomodulators. After this we have to talk about frequent lapses. So what is frequent lapses? That is like more than 2 lapses in 6 months, or 3 or more lapses in 12 months or in a year. That is also considered to be as frequent lapse. This both should be told in the definition of frequent lapse. Okay, So here also you can't be giving steroids in every relapse because of associated steroid toxicity. Start them on immunomodulators. So here two things we are tackled by the same group of drugs, immunomodulators, steroid dependent cases as well as frequent relapse. Okay. So so this is clear, right? That is immunomodulator, like again levimazole, mycophenolate mofetil, and cyclophosphamide. So now what is steroid resistant case? Okay, I told you, right, most of the cases will subside in the 6 weeks in this high dosage you are giving. So proteinuria will subside in the 6 weeks. So there's absence of remission or like symptoms are still not going away. Absence of remission despite steroid therapy for 6 weeks is a steroid resistant case. Mention this clearly 6 weeks also in the definition because Ghai mentions it. So absence of remission despite steroid therapy for 6 weeks, that is considered to be steroid resistant cases. So here what do? You evaluate the patient, send them for renal biopsy as a genetic testing, and you give them calcineurin inhibitors like cyclosporin and tacrolimus. So basically there's just like three group of things: steroids, that is prednisolone here, immunomodulators, that is the second group, and third group is calcineurin inhibitors, that is cyclosporin and tacrolimus, that is given for steroid resistant cases. So I hope now all kinds of definitions are clear from this one flow chart. You guys can take a snapshot here. Okay, so take a snapshot here, and yeah. Okay, so last one more picture I have put here, that's from Ghai itself, this picture. So this is like a child with you can see clearly facial puffiness, generalized edema is there, anasarca is there. So this child have nephrotic syndrome, which is a steroid sensitive type of nephrotic syndrome. How do you know that? Because of this purple stria that you see here, right? So the child is on a dosage of steroids, right? On a prolonged use of steroids is there. So that's why the child has developed purple stria, because you're not just giving for one day and stopping the drug here, right? It's a 6 weeks plus 6 week regimen. So there are chances of some sort of steroid manifestation that could be seen in the child. Okay. So I just wanted to put this picture here. Yeah, that's it. You guys, I hope you guys have understood clearly about the management protocol and what is to be done. Yeah, please do subscribe to my channel. Thank you.